Welcome to the Shared Path. I'm Maggie Linton. For centuries, women around the world have dreaded that time in life called menopause. With hot flashes, sleep deprivation, weight gain, plus other issues, it's time to face the problem head on. Our guest is Dr. Stephanie Fabian. She shares solutions with her new book, The New Rules of Menopause, a Mayo Clinic guide to perimenopause and beyond. Dr. Fabian is director of Mayo Clinic Center for Women's Health, chair of the Department of Medicine at Mayo Clinic in Jacksonville, Florida, and medical director of the North American Menopause Society. You're one busy woman.
Delighted to be here. Thanks for having me.
Well, we're glad to have you here. I'm so excited about talking about menopause because so many people I know have suffered greatly for it. And it just kind of comes out of the blue. They're fine one day and the next day they're not. Talk about menopause.
Well, let's talk about some definitions first. So, menopause is defined by the no menstrual cycle for 12 months. So, that means you're in menopause, but you don't really know you're there until it's been a year. But that time leading up to the menopause is called perimenopause, and that can last for 6 to 10 years before you actually get to your last menstrual period. In perimenopause, your periods may still be regular for some time, but as you get closer to menopause, you may skip a period. Your periods may get closer together. They may actually get further apart, but your ovaries aren't working as well. And so many women in perimenopause can have the same symptoms that you would experience after menopause. Those are hot flashes, night sweats, sleep disturbances, vaginal dryness, mood issues, joint aches, brain fog, some of those, but many women don't expect this because they're still having regular periods at that time. So it can be very confusing for women.
You spoke about perimenopause, and I didn't even realize there was a perimenopause, of course, as many women, because we only hear about menopause. And I was, my period just kind of like stopped, just like it started at 11 years old. At 45, I was done. And I thought, okay, I'm done. And then about 3 or 4 years into it, it started all over again. And that's when I found out about the perimenopause and the kind of up and down. Put on hormones, pills for about 3 or 4 months, got my hormones back together, and I never had another period. And I'm grateful for that, really grateful. But I'm amazed at how many of my friends do suffer for years. The stop
Yeah.
and go, the start and stop. It can be just nerve wracking.
It can be, and menopause symptoms. So average age in the United States is about 52. 95% of us are done by 56, but the symptoms can last for a mean of 7 to 9 years. 7 to 9 years. So we're not looking for short-term solutions if you're really having a problem. You need to think longer term. About a third of women will have hot flashes and night sweats for a decade or more. So again, you were one of the lucky ones, and it's funny because my mother asked me why I was writing a menopause book, and I said, "Well, that's interesting, Mom. I never really asked you about your experience. What was it?" And she said, "Well, I think I might have had a hot flash at a cocktail party once when I had a glass of wine." And I went, "Wow, that's it." But that is not the experience of most women. We know that about 75% of women are going to have symptoms, and as I mentioned, they last a long time. So for a lot of women, this can be super disruptive. Not just at home, in terms of family and family relationships and just quality of life, but also at work. And a recent study that we published a couple of months ago showed that women were telling us that they are missing days of work because of their menopause symptoms, days of work per year. So think about the economic impact of that as well. So it's a quality of life issue, but it has an economic impact for women, but also for the greater economy.
You talk about that, and so much of it, so often, and you talk about it a lot in the book, are the mood swings. And
Hmm.
it's more than just the hot flashes. In many cases, it's kind of the loss of memory. It's depression, things like that. And there are so many things that women really do have to still kind of soldier through for getting other things done as they're suffering. And so often, doctors don't really understand that they go to either.
Oh, well, you bring up a lot of good points right there. So the mood issues, you're exactly right. And in fact, we found that in our study, the main driver for having a problem at work was the mood symptoms associated with menopause. The other symptoms still were an issue, but the mood by far drove it. And so women can experience, I have a lot of women say they just get super irritable. Anxiety symptoms can be a problem, depression can be a problem. And for those women that have a problem in the menopause transition because of the loss of estrogen, that variability in the estrogen levels can cause these mood issues. We're learning more and more about that. But we know that the women who are likely to have a problem with mood in the menopause transition are the women who have had a mood issue before. So if you have had a depression in the past, you're the one that's going to be at risk for having it again at that time. Not that other women can't have a problem, but that those are the women who are most at risk. Also, those women who might have had a postpartum depression or baby blues or premenstrual syndrome where they got mood issues right before their period started. Again, those are hormonally related mood issues, and those are the women that are going to tend to have a problem in menopause. So it's important to kind of look back at your own history, and you can see if you might be more vulnerable than some other women to mood issues around that time.
Talk a lot about hormones in here
Mhm.
because women seem to explode with them. And that was the one thing I really wanted you to kind of delve into a little bit more about how much our hormones determine how we react to so many things.
Oh, yes. Well, keep in mind, it's not just our breasts and reproductive organs that have hormone receptors, estrogen receptors. We have estrogen receptors all over our whole body, in every organ system, in every tissue in your body. You have estrogen receptors in your brain, in your bones, in your heart, in your joints. So all of those are going to be impacted by menopause in some way. So when you lose that estrogen, all of those organs that are used to seeing estrogen on a regular basis and aren't anymore are going to be impacted. And so we're at our infancy and learning about some of these. For example, the joints. We know that women don't tend to get arthritis until after menopause. And we know that from the Women's Health Initiative study, we know that there's a lot more joint pain in women who aren't on hormones after menopause, and those who take hormones tend to have less joint pain. What we don't know is whether giving hormones can help preserve joints in any way. So that we don't know if that prevents arthritis or if it prevents a joint replacement down the line or anything. So there's so many things that we just don't know yet, right?
Right.
That we need a lot more research on.
You also talk about many different women, and one you gave one example of a woman at 25 years old who had to have a hysterectomy. And that can greatly change what goes on in your body also and put you immediately into menopause.
Yes, so it's important to note the hysterectomy is the uterus, but when it comes with the ovaries too, that's when you're in early menopause. So if you have your uterus and both ovaries removed, that is menopause like you weren't in it yesterday and you are today. And that's a very different experience than going through it naturally, where it may take several years for the ovaries not to work. And for those women who go through that surgical menopause at a young age, that can be really hard. So most 30-year-olds or 20-year-olds are not in menopause, and it's hard to be dealing not only with those symptoms and the loss of fertility, but there can be mood issues, there can be body image issues, there can be sexual dysfunction, and those women actually are at increased risk for a number of chronic diseases and even early mortality if they don't take hormone therapy, at least until the natural age of menopause, because they were meant to have estrogen until around the age of 50, and not having it places them at risk for a number of chronic diseases.
Hear so much about, and I experienced just some hair loss. Hair
Mm.
loss is really one of those things, the women nowadays you can throw stuff on and get it looking good, but for so many women, that is one of the major issues that they have. That
I
and
have so many women complaining about it, to be honest with you. So it's complicated. Is that an aging thing or is it a menopause thing? Well, it's probably a combination, but probably a little more on the age and genetics side of things than actual menopause. We know that changes in hormones can change your hair. So, when you get pregnant, you have gorgeous locks, and when you deliver, women often have hair loss when they deliver because their estrogen levels just plummet. So that change can cause some hair loss. So for some women who go through menopause, they can lose a little bit of hair related to the hormones. But more what we see is our hair changes anyway by decade of life, and we tend to get thinner as we get older. But there's also a genetic component. So it may be your mother you follow, or it may be your dad you follow, but you can
Dad
have
was
a gen.
bald by 25.
Uh-huh. Yeah, my dad didn't have a whole lot of hair left either, and I'm like, that's not boding well for me either. But yeah, so you can follow a little bit of a genetic pattern as well. Solutions, hormone therapy is probably not your best solution for hair regrowth. It's not going to do that much for you, but the thing that's on the market is minoxidil, and it's over the counter. But buyer beware tip. If you buy the pink box for women, it's the same stuff as the blue box, and the pink box is 3 times the price. So there's a little bit of a pink tax on there. Actually, a lot of a pink tax.
Right. Uh, I want to talk about, we've been talking about hormones. Let's talk about the diversity within hormone therapy because it's gotten a bad name, it's gotten a good name, and then there's somewhere in between. And the way it's delivered orally, transdermally, and vaginally.
Yeah, a lot there to unpack. So the Women's Health Initiative trial came out in 2002, and that scared everybody half to death about hormone therapy, and everybody dropped off hormone therapy, and doctors flat out stopped prescribing it. They also stopped educating themselves on menopause, which was another whole issue here. But since then, they've reanalyzed the results of that trial by decade of life. They were initially reporting everybody who was on hormones between the ages of 50 and 79, and they lumped all that together and they said, here are the risks and benefits. Well, I don't see a 79-year-old in my office for the first time asking for hormones. That's not who I see. It's the 48 or 50-year-old who's like sweating up a storm going, dear God, make it stop. That's who I see in my office. And it turns out for those women who are between the ages of 50 and 60, the benefits typically outweigh the risks. So it's really if you're starting hormones later that the risks are more predominant. And so for the group that we actually prescribe hormones for, the women in their 50s, it turns out the benefits outweigh the risks. So it took us about 10, 15 years of reanalyzing that data to really come out with that truth. But we have since come full circle looking at the same data and now say this is probably the best bet for most women who are in their 50s and having symptoms. Now, having said that, there are other options. Oh, you asked me about transdermal and oral. So yes, many, many different forms. You can get hormones and pills and patches and gels and sprays and vaginal rings. Let's keep in mind that the vaginal products, some of them are a full hormone therapy dose, and some of them are the low dose just needed for vaginal dryness. If that's all you've got going on is vaginal dryness, we can use the very, very low dose and just treat the vaginal tissues. But if you've got vaginal dryness plus hot flashes, then you need the full hormone therapy dose, and you could take that in any form, right? So we have come to find out that administering estrogen through the skin, such as with a patch, is probably a little safer than going through the mouth, because when you go through the mouth, you have to go through the liver for digestion. And when you go through the liver, it can impact blood clot proteins and increase your risk of a blood clot, just like a birth control pill can. So, for that reason, for women with any risk factors, like being obese or like having diabetes or high blood pressure, then we would probably go with a through the skin formulation for that.
And you just talked about obesity, and that can be that's a problem in around the world, but in America it seems to be extremely hard because of the access to food. But the need for exercise and really getting healthy really does help diminish a lot of the problems that women have with menopause.
Yeah, exercises, boy, it's great for everything, isn't it? It helps you maintain your weight, it manages stress, it reduces your heart disease risk, it reduces your cancer risk. The only thing it doesn't do is it doesn't help with hot flashes, unfortunately, but pretty much everything else. You mentioned weight. So the weight gain around midlife is probably one of the number one complaints that women have in my office. It's like they always come in and this is actually why we named the book The New Rules of Menopause, because they always come in going, I haven't changed anything. I'm doing the same thing. I'm exercising the same. I'm eating the same and I'm gaining weight. And I say, exactly. Someone changed the rules of your body and they forgot to tell you.
Yeah.
So if you don't change something around midlife, you absolutely will gain weight. And so the reality is that we're burning fewer calories, and that's more age related than menopause related because we're losing a little bit of muscle mass every year, and muscle burns a lot of calories. And so we're burning more when we're sitting there, and we're burning more when we go to the gym, or burning less when we're sitting there, and burning less when we go to the gym. So really, it takes we've got to have less in to be able to maintain that smaller muscle mass, right? So it's less in and really maintaining that exercise. You can't exercise your way out of it. That's another key point is I have a lot of women going, I'm just going to go 2 hours in the gym, then I can eat whatever I want. Nope, it doesn't work that way. So you got to go to the gym, but that's going to help you not gain. And that'll help you keep off weight you lose, but you really have to cut calories to lose weight.
Right. Well, that makes sense no matter what you're doing and where you are in life.
Yep.
Let's talk about also hormone. Uh, I'm sorry, the way you can do it, uh, lose, get your hormones in a different sort of way, more naturally, with holistic and integrated um, ways of medicine.
Well, no, those won't give you hormones.
No.
But you know, the question is, do any of the over-the-counter supplements work? Do any of the herbs work for, because you hear advertisements all the time. The bottom line is no, we don't have really good, strong evidence that any over-the-counter stuff works for hot flashes. Now, that doesn't mean it might not, that it's not useful for other things like sleep or something else, depending on what the complaint is. But for hot flashes, no, none of the over-the-counter stuff works. For other non-medication therapies, we actually know that cognitive behavioral therapy works for hot flashes. And that's probably because when you have a hot flash, there's some anxiety associated with having a hot flash. And then people get, really anxious about, oh no, what if a hot flash happens? And what if I'm in the boardroom or giving an important talk or whatever? And what if I have a hot flash and everybody sees I'm dripping sweat? So there is some anxiety associated with it. So cognitive behavioral therapy can control that part of it and can actually help you manage your hot flashes better because you take care of the anxiety component. Hypnosis is another technique that actually has some good evidence to support it. It's a little hard because not a lot of people have access to hypnosis for menopause symptoms, but you can imagine how thinking about cooling images in your head and putting yourself in say the middle of an iceberg when you're having a hot flash would be helpful. So those are two interesting things that work.
How
Some
about
of the things,
acupuncture?
the data on acupuncture is hard because acupuncture requires needles in places, but the studies that have been done don't always put the needles in the same places or use the same techniques. So they're hard to control for across all these different studies that do it a bunch of different ways. So the bottom line is we don't think acupuncture has a huge effect on hot flashes. I have had some patients tell me that it really helped them. And it's certainly not going to hurt you, but there's probably a strong placebo effect. They found that sham acupuncture in one study was just as effective as real acupuncture. So they put the needles in the wrong places for hot flashes, and they still had a benefit. So it may be that you are convinced that you're going to have a response that's positive and you're in a dark room and somebody's helping you with hands on. And so that may be comforting enough to reduce your anxiety level about hot flashes to make you actually have a difference. So, yeah.
Yeah, just keep knocking at the door and trying more than anything, right?
Exactly. There's lots of, I think the main point is that for women who are suffering, we've got plenty of options available, hormonal and non-hormonal, that actually do work and are effective and have been proven. So women don't have to suffer.
I often find that women have a problem actually going to the doctors and telling them what's wrong and how they're effective. They wait until they're literally ready to jump off a cliff before they do. And that communications needs to open right from the very beginning, doesn't it?
100% agree with you, but I think women have also been conditioned when they go to the doctor,
Suffer.
nothing gets done, or they're told that their symptoms aren't real. They're not validated when they go in. So this happens so much and is reported so often that I wouldn't doubt that women hesitate to go in and say anything because they feel like they're not going to be believed. And this happens again and again. I get people in my office who have been told that there's nothing that can be done for their hot flashes, which 100% is not true. But the other part of that is your provider, your doctor may not have education in menopause. And we know that this has dropped out of the medical training programs. It's just not in there anymore. We surveyed residents a couple of years ago coming out of OBGYN, internal medicine, and family medicine programs, and they reported at most 1 to 2 hours of education in their entire residency program on menopause in general, not just hormone therapy, but on menopause. And so the majority of them did not feel comfortable managing menopause when they got out. So that's what we've got now is a whole group of medical providers who don't feel comfortable managing menopause. So you can imagine when the menopausal woman gets in front of them, and in fact, some of them said they don't manage menopausal women. You know that they have to have a panel, the majority of whom are women over 50. So they're just not even seeing the woman in front of them as being menopausal, right? They're just not even registering. So you can imagine when they go in the office, they're probably told that, oh no, you can't do that, or nothing works, or just poo-poo your symptoms, you know. So they're getting dismissed a lot, which is super unfortunate. So one tip, menopause.org is the Menopause Society, has a located provider tab. You can find someone who is certified in menopause management in your area if you're not having luck with your own provider.
How did you get interested in it? Because you've become one of the leading authorities on it, and I know you've been working with women's health for over 18 years, so it wasn't like the light bulb just went on this year to write a book.
No, well, okay, this it's kind of a funny story actually. I tried everything I could not to go into women's health. Everything. Literally, when I graduated from my residency program, everybody, because I was a woman, said, "Of course, you want to write the women's book or be in the women's clinic or whatever, be in the breast clinic." And I'm like, "No, no, 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 no. I just want to practice medicine." So I resisted multiple attempts to move me into women's health until the Women's Health Initiative study came out in 2002, and then my patients were coming in saying they couldn't get hormone therapy, they couldn't get treatment for menopause symptoms. And that's when I got mad. And so I think it took me getting angry about the fact that women weren't getting the care that they needed. We actually started our menopause clinic at the Mayo Clinic in Rochester 3 years later in 2005, in response to the fact that women couldn't get treatment. So it really took that event to move me forward.
I find so much, the men can get their little blue pill immediately, and they want to tell us what to do with our bodies when it comes to birth and things like that. But yet, the continuing care of women still continues to be, I won't say on the back burner, but at least it's moved to the middle burner. And there's still so much more that needs to be done.
100%. I saw a beautiful quote in the news recently, and the quote was, "We know a lot more about the bottom of the ocean than we do about menopause." And the next sentence was, "That's because the military is interested in the ocean." And so the research agenda has not been directed to women's health because it hasn't been a priority. And frankly, women weren't driving it. And so I think that's starting to change. And I think women's voices are being heard, that their issues are important. And, women's health is about men's health too. So we need to know about all diseases and conditions, about how they are different between the sexes, how they're different in women than men. And they may not be for everything, but there may be important differences that we haven't looked at that we're just flat out missing. So you're right about that.
Our book is so well written and easy to read. And I love how you kind of get into it, but you start with the three, what I wrote down three topics: understanding, management, and owning it. And owning it to me was the real one that just needed to be, and just say, okay, this is it. Let's do something about it. You don't have to be miserable for the rest of your life.
That's exactly right. And keeping in mind the rest of your life is a long time,
I'm
right?
willing.
So it's about 30 to 50% of your lifespan. And so really how do you move forward after the menopause transition and take charge of your own life and do what you want to do. And a lot of women think they go into it with the attitude of, oh, it's over. It's not over. It's the second half. So now is the time to sort of take a step back, reassess, make sure your health is where you need it to be, both mentally and physically. And are you spending your time doing what you like to do? Do you want to, what's the hobby that you never took up that you wanted to, or that you used to play piano back in the day, but you don't anymore, or you want to learn how to be a chef, whatever it is. A lot of people have a second act that is even more rewarding than the first act.
Very true. Anything else you'd like to give as a good point for these ladies and women out there who are ready to move forward with their lives?
Well, I just think of this transition in a positive light. If you are having trouble with symptoms, keep in mind we can do something about those. Don't let anybody tell you that you just have to live with it, because you shouldn't suffer. Yes, everyone goes through this. Menopause is not a disease. Let's be clear about that. It's a natural and normal part of life, and we should be able to talk about it. So if you've got symptoms that are bothering you, bring it up with your provider, and if your provider doesn't have the answers, then you know where to go for answers. This book is one option. MayoClinic.org is another option. Menopause.org is another. So you've got resources out there.
Right. Well, many thanks to Dr. Stephanie Fabian. Her new book, The New Rules of Menopause, a Mayo Clinic Guide to Perimenopause and Beyond, is available through Mayo Clinic Press, Amazon, and other locations. And don't forget, menopause.org. Until next time, seek peace and spread lots of love. I'm Maggie Linton.